Okay, well, welcome everyone to our uh, July training within our Gero competency series from the Older Adult Behavioral Health Initiative. Today we are with Nirmala Dhar, and just a few training details. So we ask you to mute your mic. You are going to receive a follow-up email with all of the slides, a link to the recording, any of the training materials that Nirmala wants us to send out to you, and also surveys for CEUs and for certificate of participation or completion. So the recording's posted to our YouTube channel that has over 50 other trainings that are available to you. And then we, just a little background on the Older Adult Behavioral Health Initiative. It was started in 2015 to meet the needs of older adults and people with disabilities, to improve access to care from qualified providers. And there are 24 specialists across the state. Every county has a specialist that is assigned, and we are an amazing resource. So please find out who your specialist is in your county if you're not within Josephine and Jackson. And we work on collaborations and coordination. We have community partner coalitions that we head, high-risk teams, and we do lots of workforce development trainings like this. And we also do community health and wellness and complex care consultations. So all of this is funded by the Oregon Health Authority, and we love working with all of our community partners. We have some upcoming, I'm going to go back, trainings. So in August, I'm going to be presenting on advanced care planning, a little deeper dive into how to make it more accessible to everyone. And then also in September, we have Dr. Avila is going to be talking about the mental health advanced directives and how to utilize that form with clients. So it's going to be an intro into that. Okay, and I think that I'm going to hand it off to Nirmala. And Nirmala is going to give a more complete bio, but Nirmala is our project director of the Older Adult Behavioral Health Initiative, and she is a licensed clinical social work and has a master's from, is it St. Louis
Oh,
University?
Washington
University of
University
Washington, yes, in St. Louis,
in St.
and
Louis.
Bombay, India. So yeah, so I'll let you finish introducing yourself because you
Okay.
have over 30 years of amazing experience and knowledge.
Yes, give me a moment. My PowerPoint seems to have disappeared. I will pull it up in a minute. I thought I had it all ready, but okay, I have it now.
Perfect.
Okay, so let me share my screen. Share my, and put this in a slideshow format. Please tell me that you see this in a slideshow format,
Yep,
Angela.
it is
Okay.
all good.
Okay, well, thank you all for joining us this morning. I'm impressed with the number of people who are here. I recognize several names because you come to a lot of my trainings. So welcome, everyone. We are going to talk about self-neglect. My topic today is self-neglect, obviously in older adults because that's our scope of work. And I'm sure you've all asked this question, why won't my client take care of herself or themselves? So that's my topic for today. Very quickly about myself, I'm a licensed clinical social worker. I'm an immigrant from India. I have worked for 40 years in primarily safety net, behavioral health safety net in the public sector with complex care clients and older adults. 22 of those years were spent in community mental health programs across 3 states. I'm a trainer and content developer. And I, like Angela said, am the project director for the Older Adult Behavioral Health Initiative, among several other projects that I manage. So, does this look familiar to you? Take a moment to look at these pictures. And by the way, I can't see anyone. So Angela and Janine, if someone is trying to say something to me, I can't see anyone because I just have the one screen. Okay. So does this look familiar to you? Take a moment to reflect on these pictures because it sure does look very familiar to me. So my learning objectives are that you will learn what's a definition of self-neglect. And what are some different kinds of self or types of self-neglects? We will look at risk factors. We will look at the complex intersecting issues like hoarding, fundamentals of capacities, the nuances of duty to protect and self-determination. And then very briefly, we will discuss interventions and resources for professionals. So I'd like to begin with this. Neighbors called authorities to check on the welfare of one who is their 91-year-old neighbor. Police found he had serious medical condition and was unable to take care of himself. There was garbage and rotten food all over the house. The house had large holes in the floor. There was exposed electrical wiring, and parts of the roof had fallen through and were open to the sky. Here's another one. Anastasia is 89 years old and lives in a trailer with her 9 cats. The cats are underweight, flea and tick infestations and eye infections, the 9 cats. Her trailer is piled high with old papers and bags and trash, and there's a narrow path that leads from the door to a reclining chair. And there's a very strong odor of urine and feces throughout the house. Anastasia has open wounds on her leg, which she claims are caused by killer rays that are coming through her window. And then there is Sam. He's an older man who lives alone with 2 dogs in a very remote area. When someone calls the state APS hotline to report that a supposed friend is financially exploiting him. So APS specialist caseworker goes to the man's home. She finds this 86-year-old Vietnam veteran who is in a dirty, cluttered house full of empty liquor bottles. His legs are swollen by chronic cellulitis. He can barely walk. He has missed his doctor's appointment. There are medications all over the floor that he needs for his cellulitis and diabetes. He does not have a functioning toilet. He prefers to urinate in plastic those plastic milk gallon jugs. He doesn't clean after his 2 dogs. So obviously there's feces and odor, and he isn't eating well. So as you can see from these pictures, and by the way, a lot of these cases I'm speaking from experience because for more than 10 years, I was a geriatric mental health specialist with Clackamas County Behavioral Health. And I went on many, many, many risk visits with Adult Protective Services in my county. And let me tell you, I have met all those not exactly these cases, but very similar people to what I was showing you. So it's very challenging work. It's not easy work. The presentation is varied. It is influenced by a complex mix of personal, mental, physical, social, and environmental factors. The high risk it poses both to the individual and often to others who are in the home or live close by. The possibility that adult services intervention is not welcomed by the individual, so making engagement difficult. The challenges of assessing for mental capacity, ethical dilemmas between respecting autonomy or choice or self-determination and fulfilling your duty to care, your ethical obligation, as a professional or as a APS worker or a mental health provider. Systems of work within our agencies that prioritize short-term, task-focused involvement rather than long-term relationship with people. So we want a quick fix to the problem. And then very often, and this is still true today, even though I identified it more than 20 years ago when I was working for Clackamas County, the need for coordinated interventions from a range of agencies. It has to be a team approach. So here are the challenges. So I got these next two slides out of Britain. The UK is doing some great work on self-neglect. So look at this. What professional, that is all of us or APS, or if you're mental health going with APS, think an adult who self-neglects might hope and fear when they see you arrive in their life. So this is what you hope. I hope they will listen to me. They won't disappear or change too frequently if I get to know them. They will provide food. They will be respectful. So you think this is what they are thinking. They will leave me alone. They will help me. They will sort my problems out. They will be sensitive and understanding. They will manage my health care and care needs. They will see me as a person. They will listen to me. So this is what you think that person is thinking or hopes for. This is what the client actually feels. What clients fear will happen when professionals enter their lives. I fear I will lose my independence. They will make me do things. They will take away my things. They will put me in a home, a nursing home. They will make me feel distressed, upset, and anxious. I will lose control of my life. I will lose my identity. I will be arrested or prosecuted. I will lose my home. They will evict me and I'll become homeless. There will be repercussions which I will not like. They will judge me. So just reflect on that for a moment. This is what they fear when we enter their lives, people who self-neglect. And so, building that trusted relationship where you are truly taking time to understand the individual's meaning and experience of self-neglect becomes really important, correct? And I just told you earlier why this work is difficult, because our systems of work want us to move fast, correct? Find solutions, get the task done, as opposed to this is going to take time, but this is the real work that we need to be doing. And, where we are negotiating things versus imposing things on the person who self-neglects. And look at that, sensitive wide-ranging interdisciplinary assessment. That is what we should be focusing on. Persistence and patience in seeking engagement and trust. Now try to fit that in your caseloads and in your work structure. Care and support by consent. Start with what can be agreed upon. Let's begin there. So again, this is hard work. And how do we build this trust? And how do we authentically listen to understand what is the meaning and experience of self-neglect for this particular person? And that's what really person-centered care is. So what is self-neglect? And I'm going to give you like 3 definitions here. So it is a lack of self-care to an extent that it threatens personal health and safety. And you saw that from some of the case scenarios I shared. Neglecting to care for one's personal hygiene, health, or surroundings. Inability to avoid harm as a result of self-neglect. No, it could be financial exploitation. People have just moved into your home like strangers. Let me tell you, I've seen that. Failure to seek help or access services to meet health and social needs. They're available to you, but you have failed to access them or even accept them. Inability or unwillingness to manage one's, personal health and safety. So this is like a 3-part definition. And if any of your clients even endorses one of them, that would indicate self-neglect. Persistent inattention to personal hygiene or their environment. That means their home environment. Repeated refusal of some or all indicated services which can reasonably be expected to improve their quality of life. For example, hey, we can fix your roof. In the one case where there was a hole. But no, I don't want you to do it. 3, self-endangerment through the manifestation of unsafe behaviors. For example, refusal for wound care, creating fire hazards. You saw several of those case scenarios I said, where there was really unsafe behaviors, open wounds, swollen legs and cellulitis, dogs who were, defecating, cats with tick infestations, paper and bags which are fire hazard. But no, we won't accept help. So any of these, if your client endorses, it meets the definition for self-neglect according to this scale. And here is the definition from the National Association of Adult Protective Service Administrators. An adult's inability due to physical or mental impairment or diminished capacity to perform essential self-care tasks, including obtaining food, clothing, shelter, medical care. Remember, we talked about personal health and safety. Obtaining goods and services necessary to maintain their physical health, mental health, emotional well-being, and general safety. And managing their finances in a way that helps them meet their needs. This is the national definition. And finally, here is our Oregon Adult Protective Services definition. Self-neglect means the inability of an adult to understand the consequences of their action or inaction, correct? When that inability leads to or may lead to harm or endangerment to self. So it is the inability of the adult to understand the impact. Hey, this will happen if you don't do this. And that inability can lead to imminent harm and danger to that person. So this is what Oregon's Adult Protective Services operates under, their definition. I love this conceptual framework. You will be getting my slide decks. I'm not going to go over every little square here, but as you can see on your extreme left, they have given you factors which kind of are risk factors in a way. Physiological factors, which could be cognitive and physical functioning. Psychological factors, if you have extreme depression, extreme anxiety, I would also say untreated schizophrenia, for example. Social and environmental factors. You lack social networks, connection to family and neighbors. And then other factors like your age, sex, health literacy, all of that. And we are going to go over all of that. I really like this framework. And when you get this, I would highly recommend that you take a deeper dive into this framework if you are doing self-neglect work. And I have the citation there too for you if you want to read the whole article. So bottom line, this is what self-neglect is. First, lack of self-care. Examples could be neglecting personal hygiene, neglecting nutrition, hydration, medication, or healthcare. Second one is lack of care of the domestic environment, your home environment. It could be squalor or hoarding, or animal hoarding, or feces. We know I've showed you, we talked about all those case scenarios. And the last one, which is often very tricky and very complex, and I think gives all of us a lot of angst, is refusal of care or services. That would mitigate the risk to safety and well-being. So lack of self-care, lack of care of the domestic environment, and refusal of care of services. That is essentially what self-neglect is. I like this, unable and unwilling. How do you assess for that? Self-neglect happens because the person is unable to manage to care for themselves or for their home, because they're either unwilling to do so or sometimes unable to do so. So both. And how do you kind of differentiate that, correct? Also, in my opinion, and in the opinion of professionals, self-neglect should be seen on a continuum. So it can range from being like mild self-neglect to very severe in nature, where you are at imminent danger of like death. And let me tell you, 6 months ago, I was consulting with Tillamook County on a gentleman who was near death. He was removed from the home and taken to the emergency room. It was so dire from a self-neglecting situation. So that would have been very severe, where where the EMS and ambulance was called, and he was removed, and he never could return back, because we proceeded with capacity evaluations and getting a guardian. He was that close to death. Severe self-neglect, so that was severe, right, is defined as unawareness to the hazardous and progressive decline in personal, social, physical, mental, or environmental domains, leading to the inability to maintain cultural and community standards. Here we are not talking about Martha Stewart standards, cultural and community standards of acceptable living that threatens the person's safety, health, and quality of life. So remember, it's on a continuum. It's best to intervene when it's mild, correct? Because when it's severe, it's often at a point where it is so dangerous that we have to intervene and remove the person. So again, I liked this one, so I wanted to share that. Remember, I said continuum. So there's also add on to that severity and urgency. You know, when we talk about severity, it could be impaired quality of life all the way to death, like the gentleman I was telling you about in Tillamook County, who was, by the way, he was about 87 years old and a veteran. And then urgency. Is it like gradual or, like mild? Is there heightened imminent risk, or is this an emergency? Wow, we need to intervene now. So these are all tips and tools for you in the field, to use. What's the severity? What's the urgency when you are making your assessments or you're consulting? So now that we have, a good definition of what self-neglect is, also introduced a bit of that framework, I want to introduce this concept of executive functioning. What is executive functioning? And I know many of you have come to many of our other trainings where we've talked in great length about the brain, we've talked about cognition. So executive functioning is a cognitive skill, which is absolutely essential for independent living. It's a set of skills. So executive skills, functioning skills are important processes in our brain that help us finish tasks and meet our goals. If you have to take medications for cellulitis, that's a task, and your brain works in such a way that I have to take my medications at 9, 12, and 3 o'clock, and you go ahead and take it. And the fact is, we use these skills for everything we do every day. You've used all those skills to get to this training today. Did you know that? You planned for it. You took permission from your supervisor. You made sure Angela and Janine sent you the Zoom link. Then you put it in your calendar. That was, planning, anticipating, starting, initiating it. So by logging on. So you used all of the skills to get here today. So it's an umbrella term, but each skill in that is very valuable. And I'm here, you will be getting my slide deck. Unfortunately, this talk is not about cognition. We do a separate one on that. But there are many skills in executive functioning. For example, self-monitoring, self-awareness, self-regulation, problem solving, managing your time, starting and ending a task, regulating your emotions, being flexible. Those are all, by the way, cognitive brain functions. And so with that little introduction to executive functions, I want to introduce the concept of executive dysfunction and self-neglect. And what does dysfunction connote? That there's something wrong with your brain. There's something impaired about your executive functioning. So executive dysfunction is defined as the inability to complete complex tasks, such as managing your finances, preparing meals, taking actions about your health and safety. These all require very high-level cognitive abilities. So increasing complexity of medication regimens, For example, that was my gentleman with 87-year-old veteran in Tillamook, has proven to be a risk factor, contributing to executive dysfunction and self-neglect. So the higher the complexity of your health problems and your medication regimen, and you're having any kind of executive dysfunction, you're not going to be able to manage your health and safety. Did you know that medication non-adherence could be a manifestation of self-neglect? So I want you to really understand this concept of executive dysfunction. Moreover, when you have this executive dysfunction, you have an inability to start or halt actions, plan for future events, inhibit inappropriate behaviors, or have alternative plans very quickly so that you can meet your care needs. You're not able to do that. And there are several medical conditions, such as major or severe depression, diabetes, dementia, some psychiatric illness, if you have had TBI, where your frontal lobe is affected, all of them are associated with the development of executive dysfunction. And guess what? One of the risk factors is age. And I know many of you talk about capacity, so there is executive capacity. It is sometimes described as a person's ability to walk the walk and not just talk the talk. What does that mean? It means that you have the mental capacity and the ability not only to understand the consequences of a decision, but you can also carry out the decision. So not only do you say, yes, I know I have to take my medications 4 times a day. This is the dosage for my cellulitis. But you can also carry it out. What does that mean? You have memory, so you remember. You have learning, so you've learned the regimen. So memory, learning. You have planning. Hey, if my medication runs out, I need to order it. So can you see it's much more complex, right? Carry it out. So very simple, we call this tell me, show me approach. Ask the person to tell you how they do something and then ask them to show you how they do it. So that's executive capacity. That means I can actually do what I'm saying needs to be done to keep myself safe and healthy. So I am going to leave this here for you all to take a look at, but here are some factors that can be mistaken for or lead to self-neglect. Someone who's eccentric. They're eccentric. They may not be self-neglecting. But in our culture, rich people are given much more leeway to be called eccentric. But when you're poor, you get identified much early on as a self-neglector. Or lifestyle that vary from the dominant culture. That may not be self-neglect. Some religious and cultural beliefs. Use of alternative medications. You may think that they are not taking care of themselves. Trauma. Low health literacy. I can't tell you, I can spend a whole hour on low health literacy and self-neglect. When perhaps your health literacy, sometimes just plain literacy, is impaired. So you can't follow directions, how to take your medication, what the medication is. And pretty soon, it's all over the floor.
Nirmala,
Yes.
There's a question in chat.
Okay.
Cindy has asked, is cognitive impairment considered a part of executive dysfunction, or is it a different concept or definition?
No. So cognitive impairment is like a global term. Which other term is we use dementia, neurocognitive disorder. Executive dysfunction is one aspect of cognition. There are many skills in cognition, like memory, learning, speed of processing. So one whole bundle is called executive functions. So yes, they get impaired in cognitive impairment. They can be used synonymously. So I want to just give you a little bit information on low health literacy. How many of you do a assessment whether your client who is self-neglecting or even on the mild end has enough health literacy? Because let me tell you, most older adults in the United States have very poor health literacy. So what happens is they may make errors with their medications. They may not comply with the medication because they don't understand. They lack the skills that is needed to be assertive patient in your healthcare system, and this puts them at high risk for hospitalization and emergency room use. If any of you are interested in knowing, having a class for your older adults on health literacy, I know Janine and maybe Angela, you are also, they're going to be offering something called the 4Ms for older adults to be more assertive about their healthcare. Because absolutely known fact that this current cohort of older adults have very low health literacy. And that can exacerbate self-neglect situations. So doing a assessment on health literacy would be key part of your assessment, whatever your role is. So here are the domains of self-neglect. Remember, we were going to talk about the different types of self-neglect. Physical and medical. Physical factors could include limitations to your client's functioning, like they can't walk, or there may be some kind of developmental disability. I remember I did an assessment on a person when I was working for Clackamas County. She was 92 years old, lived in her trailer, and had severe arthritis, mobility problems, but refused to leave the trailer home. And what would happen is she would fall, or she would sit on the commode and couldn't stand up, or sit on a chair and not stand up, fall multiple times. She would call 911 at least 15 times a day, non-stop. Like she wanted them to come and pick her up or lift her up or move her from the chair to the bed. So much so that she was eventually charged with 911 misdemeanor. We had made all the possible referrals to APS, everything. She refused, and finally she went before the judge because of the misdemeanor charge and came to me for an evaluation. And really, we concluded that she did not have the decisional capacity, and she was putting herself at risk and the community at risk when she was taking away vital emergency services from others. And that there were absolutely services available for her, such as moving to an assisted living facility where she would get the kind of care she needed. She, of course, refused, and so we had to go the route of a guardianship. Then which eventually got her into a assisted living where she was taken taken good care of. But it was a long, circuitous path that we had to take, because every step of the way we wanted to be respectful and support her autonomy to the extent we could. So physical factors play a role. I have many other stories about another situation where I was working with a mother-son duo who both had, some developmental disability. So absolutely medical factors that can impact a person's ability to care for themselves, such as insulin-dependent diabetes or kidney failure that requires dialysis or special diets. And remember, we talked about low health literacy. How do you measure how many carbs I took and when should I give myself insulin? What happens is medical non-adherence, medical emergencies show up at the ED with often adverse events like amputations, for poorly controlled diabetes, or kidney failure can lead to death. Then there's psychological and mental health domain. Examples are severe depression, severe substance use disorder, trauma, dementias of all kinds, severe anxiety where you're not leaving the home and living in all that filth. All of this can lead to self-neglect. Then there's environmental, we talked about, where your environment is unsafe, where you're unable to maintain like just everyday maintenance of your home, or your utilities aren't working, or you have no working appliances, or there's so much newspaper and bags that you can't enter the bathroom or the kitchen, which, by the way, I've seen many times. We talked about infestation, structural damage, unclear paths, in the home, smoking with oxygen. Then there's financial, where you are unable to manage your finances, and so you are not able to pay your rent or get food or medications or pay for your utilities. I mean, this is a repeated pattern. Or someone is exploiting you, or you are at risk for exploitation. And then that social and cultural. Social, maybe you just lack social support, or you have that low health literacy, or just literacy. You may not be able to read really well, and you really don't know anyone to ask for help or assistance. And there are some cultures where asking for help is very shameful, outside of your family. Or you may be afraid to ask for help because you may think, oh my gosh, the government will deport me or whatever. So these are the domains of self-neglect, or the different types. So what's the prevalence? This was, there's not really very good studies on prevalence because, this is some ways somewhat of a hidden problem, right? But there was this big study done in Chicago in a health and aging project study, where they suggested that 1 out of 9 older adults experience some form of self-neglect in a community setting. It could be from that, what I said, from mild to severe. Other studies have shown it as high as, 29 or 18%. Suffices to say, it is a substantial problem, especially as we have an aging population. And we have an aging population in Oregon. Did you know Oregon is the oldest state west of the Mississippi? And last year, Oregon passed a demographic watershed where we now have more older adults than kids under the age of 18. Last year, it happened last year. So we are an aging state. What services and supports do we have in place to prevent mild self-neglect to becoming more severe and placing people at risk? Why? Because the consequences of self-neglect can be dire. Higher rates of illness and death. Like the gentleman in Tillamook, we could not let him return home because he had nearly died. Higher rates of emergency room visits and hospitalizations. They are more at risk to suffer from other forms of elder abuse. Mental illness such as depression, social isolation are demonstrated risk factors that we should be doing something about. So here are some characteristics of people who live alone that could be like a red flag for you when you come across a client or someone that you're called to consult on. They more likely live alone, most often women. They are quite depressed and increasingly confused. They are frail and older. They could have alcohol problems. And they may have a long history of poor personal hygiene or living conditions. You know, it didn't reach the level where APS neighbors were calling people, but they've had a history of that. So in the home, the red flags are, you know, there's not enough food, water, heat. There's odors, it's filthy, hazardous, unsafe. Home needs major repairs. They're human or animal feces. There's some kind of hoarding going on, animal or insect infestation. This is all that you need to be looking out for. And these should raise a red flag for you and anyone in the community. If there's a repeat pattern of unpaid bills, like utilities, for example, are shut off, that every time you pay a home visit, there's no food or there's spoiled food all over the home. Pest infestation, trash piled up, poor personal hygiene, unorganized or expired medications, weight loss. They are frequently falling. The home is in a state of disrepair. Lack of medical care. You can see that, you know, they have significant medical issues, but they haven't gone to the doctor. Untreated wounds, sores, or dirty bandages. Lack of assistive devices like glasses, hearing aids, canes, walkers, though you know they will benefit. So these could all be like indicators for you to be on the lookout for. And I really like this little icon, which really explains why could a person possibly self-neglect? It could be a brain injury. It could be that cognitive impairment. Someone talked about dementia. It could be a very serious mental illness like severe depression or schizophrenia or psychosis, late life psychosis. Isolation and lack of family and friends. Poverty and lack of finances. Physical illnesses which impact your everyday living. Pain, addiction like alcohol use. And then trauma. Any of this or several of them can cumulatively could tip you over into self-neglect. And so, you know, I am a mental health professional. You know, my work with Clackamas County, I was the mental health professional working with APS. And so always, you know, have we ruled out dementia, depression, psychiatric illness, and any other thing that's going on? Remember that executive dysfunction, which then leads to these impaired ADLs and this kind of self-neglect situation. So this is a nice scheme here of, you know, what should go into a thorough assessment for self-neglect. And remember, I used to do these assessments when I told you about the woman in Wilsonville. You know, this was all what I did in my assessment and then came to my conclusion. So then I also want to just bring this thing, the concept of intentional and non-intentional self-neglect. Intentional is, hey, it's a lifestyle choice. I'm making a choice to live like this. I want to maintain control. I'm the captain of my ship. It could be a personality type, or you fear that you're going to be put into a nursing home. Non-intentional is where you really don't have that awareness at all, because you have a cognitive impairment, severe psychiatric illness, significant functional illness. You may be using alcohol or other substances, or you've just gone through experiencing a very major life stressor. And so, why are we all here today, correct? What's the importance of this topic? Because it is, if I'm right, and I'll show you the data, the second most common referral to adult protective services now in Oregon. It's a risk factor for premature death or early death for older adults. It can co-occur with other forms of elder abuse like financial abuse or physical abuse. So that's the significance of why we are all here. And the fact of the demographic realities in Oregon, right? That we are an aging population. And guess what? As we go east from Portland, Oregon becomes more rural. Many of the counties that are represented here are considered rural counties. And as we go rural, the population ages. Some of our oldest counties are in rural Oregon. So here is that, this was what I could get the latest data. This is the 2021 abuse allegation. Okay, these are not substantiated, but these are what came in the door, and you can see 21, the blue here, 21% were self-neglect. Obviously, the biggest was financial abuse. And then you can see verbal abuse and self-neglect were almost the same. So it's a huge number that gets referred. And here are some examples. I gave you some case scenarios earlier, so we won't go to all of over them, but persistence declining or refusing medications and or any other kind of healthcare support. Continuing to refuse to allow access to healthcare staff in relation to personal hygiene and care. Living in very unclean, sometimes vermin infested situations. Not having a working toilet. And I want to tell you this very brief scenario, again, with the utmost respect for the person. I was involved in the consult where this man had maggots in his bottoms. And we had to do an emergency removal to the hospital, like real live maggots. Neglecting household maintenance. Obsessive hoarding, which is now recognized as a mental health diagnosis, hoarding disorder. Very poor diet and nutrition where you're losing weight every week. And so I know we've gone over some of the risk factors, but medical comorbidities, especially chronic health problems. People here, we as Americans have 2, 3, 4, 5 chronic problems by the age of 66. Now imagine trying to manage all of those when you're having problems with your brain. Mental health problems can impair your ability to make decisions and carry out the kinds of plans you need to be safe and healthy. Severe mood disorders like depression, anxiety, psychosis. Sensory impairments like vision and hearing loss may make you very isolated and cut off from social networks. Physical limitations like the client I talked to you about in Wilsonville. She had mobility problems. I mean, she also had cognitive impairment, but she also had mobility problems. Adverse life events, emotional, we talked about that, and poor health literacy, we've already talked about that. I can't emphasize poor health literacy. For example, failure to take the full course of an antibiotic medication because they're feeling better. That's kind of a lack of health literacy. No, you need to complete the course. So this was a study which I found interesting. People who live in squalor, they often have diagnoses of dementia, alcohol use, schizophrenia, or some kind of personality disorder. So think about it. When you come across a situation or refer to a consultant that, hey, there's this person living in squalor, your mind should absolutely go to that differential diagnosis. What's happening? Do we need to rule out psychosis, alcohol use, dementia? Because that's what the literature says. And then another study said that poor personal hygiene, where you are just self-neglecting your hygiene, are linked to that frontal lobe. Remember, I told you executive dysfunction. By the way, that resides in your frontal lobe. Executive frontal lobe dysfunction. This can result in self-care deficits and can spiraling and can spiral into health and safety issues and refusal of services.
Nirmala, let you know that we're at 10 o'clock.
Okay, thank you.
Yeah.
So again, here I'm not going to go over all of that, but there are all of these risk factors. We haven't talked a little about dementia. Yes, dementia is a risk factor. The lady that I was talking about in Wilsonville, she had mobility problems and she had dementia, where she was unable to make those decisions about, hey, these are the consequences. I can't call 911 for help, 10 times a day. They need to be working with others who are in real emergency. She couldn't understand that. Depression. Do you know there's a subset of depression in older adults where they develop that executive dysfunction that I talked about earlier, where you're so severely depressed that you're unable to take care of yourself. We've already talked about alcohol use. It can lead to malnutrition, dehydration, anemia, injuries, dementia, because it affects your brain. And all of these others, anxiety, schizophrenia, personality disorders, especially there are, we have clusters of personality disorders, but there is one cluster where those disorders they're very suspicious, mistrustful, paranoid. So those more severe kind of personality disorders all could lead to self-neglect. Metabolic and other organic disorders, delirium, which is a sudden acute onset of mental status changes. It is a diabetic ketoacidosis, or you have very high calcium, or infections because you're not taking care of yourself. We've already talked about sensory impairments like vision and hearing, which can lead to lack of social contact or very small social network. And then physical impairments such as mobility. Or it could be you have chronic congestive heart failure, or you can't breathe because of COPD or arthritis. So it limits your ability to take care of yourself. But you need to be aware that I need to get help for that. We've already talked about social isolation. It could be due to separation, divorce, widowed. Remember, we talked about major stressor that's happening. Poor social networks. Low education. So it could be health illiteracy, but also just literacy, unable to read. And pride in independence. We as a culture and society value independence, right, above and beyond anything else. You will get this. This is a nice one pager to print and keep on. What are some self neglect risk factors for like a quick cheat sheet reference. So I've included that in my presentation for you. So we've already talked about severe depression and self-neglect. Depression has been shown to be an independent risk factor that can red flag that, hey, self-neglect may be coming. And then I talked earlier about this variant of older adult depression, geriatric depression, which actually affects executive functioning and results in this executive dysfunction that I talked about, which then can lead to this kind of neglect of health and safety. So absolutely doing that assessment, hey, is this underlying cause depression? So I know I often get pushback from our APS world, etc. We only look at not at diagnoses, but at function. But here it is, you also need to see what is the underlying cause. Can we address it? Can we offer help and services? Because that's what equity is about, right? So if it's depression, what can we do? Can we be referring them somewhere? Could they get some medications for their depression? Not that you are a mental health therapist, but you are recognizing what's the underlying cause. So needless to say, depression symptoms are estimated between 50 and 62% of the time in this one major study. That means more than half the people. Whether it is a full-fledged depression or even subclinical depression. That was very evident in people who self-neglect. And those who had a positive screen for alcohol abuse were 3 times more likely to have that subclinical depression, which was, a risk factor then for self-neglect. So also pain. So all of these are like red flags for you to include in your self-assessment. Sorry, in your assessment of self-neglect. And so here is the policy and practice implication for all of you who work in agencies and elsewhere. That depression is a condition that should always be assessed when an older adult has been confirmed to have self-neglect. Because if you're not going to address that, it's going to perpetuate that self-neglect. It's not going to change. And so it becomes important to understand and actually create a policy and practice. Hey, if I can't assess it, I'm going to ask someone else from my team to assess it. And then see what do we need to do to mitigate this person's risk. And then there is that cognitive impairment, dementia, and self-regret. Just look at the pictures of the brain. This is the healthy brain. This is the one on the left is the brain on a brain with dementia. You can See obvious changes, right? It is smaller in volume. The coloration is different. There are large holes in there. Why? Because in dementia, you have neuron or brain cells actually dying every day, and they don't get renewed. And so wherever that's happening is you lose that part of your brain function, those cognitive functions. So highly, highly plausible correlate of self-neglect. That means high, high correlation between dementia and all of the self-neglect cases that we look at.
Nirmala, there's a question in the chat
Uh-huh.
Around dementia or
Okay.
depression. So is depression considered voluntary or involuntary neglect?
So remember I said we need to do an assessment. It would be considered involuntary in my opinion. That means you are so severely depressed, you have that executive dysfunction that you're unable to make the kinds of decisions you need to for your health and safety. Therefore, assessing for that becomes very important. And beyond just assessing to know the presence, assessments using valid screening tools also tells you how severe the depression is. So absolutely, yeah. So similarly for dementia, because I just said that it's highly correlated with self-neglect. Why? Because you need all of those executive functions that I was talking about earlier to really provide for your health and safety, especially if you have chronic multiple medical problems and you have to take care of your structure of your home, be sure that you have a budget to meet all your needs. You need that cognitive bandwidth. But look at the brain on dementia. Capacity gets impaired. Your capacity to do all of this. That's what happened to my 87-year-old gentleman. We went the route of a guardianship then. Then there is hoarding and self-neglect. Remember I said now hoarding is a mental health diagnosis. It's called hoarding disorder. What is it? Persistent difficulty in discarding or parting with possessions due to the perceived need to save the items and distress associated with discarding them. It's the accumulation of possessions that congests and clutters active living areas and compromises their intended use. And it causes clinically significant impairment in functioning. And hoarding disorder is anywhere between 2 to 5% in the community. Look at how it impairs daily living for older adults when they're hoarding. And I showed you some pictures at the beginning. Unable to walk in their homes, unable to use their sofas, unable to prepare food because the stove is all covered, unable to use refrigerator, kitchen sinks, bathroom sinks, toilets in the bathroom. It's that severe. And here are health consequences of hoarding disorder for older adults. Biggest is falls. As you know, we already 1 in 3 Oregonians falls. Now, imagine if you're living in that kind of cluttered house. It exponentially increases your risk for falls. Fire hazards. I've done an evaluation on a woman who hoarded from APS. And I took it as a lifestyle choice, but I put in my evaluation that the potential for hazardous fire was very real. And guess what? About 3 years later, that's exactly what happened. She used to light candles. It was a trailer park. The candle fell over, tipped over, and set the whole fire ablaze because of all the paper she had. Poor hygiene, poor nutrition, medical exacerbation of medical problems or new medical problems, food contamination, social isolation, decreased independence, inappropriate medication management, homelessness because you often get evicted. And then there's alcohol abuse. I've already talked about that. It's more common in older adults than we think. It is highly associated with people who self-neglect. Very predictive of high recidivism rates for APS. So do you assess for that? Do you inquire about that as part of your assessment of self-neglect? And then we talked about squalor, right? High rates of mental health disorders. It affects young and old people. And really what this study looked at, there was a large group of people with intellectual disabilities who were aging and living in squalor. So with all of that risk factor now, in our rear view, what is the gold standard for assessment? I've already talked about that. It should be a multidisciplinary geriatric assessment. I'm talking about older adults, obviously, here. And when I was in Clackamas County, I was part of a program that did that. I was the mental health person on that APS team. Medical, cognitive, mental health, psychosocial, functional, all of this we need to be evaluating. Doing some cognitive assessments, figuring out what are those ADLs that they can do, what can they not do, assessing what is their social network, screening for depression and other psychiatric disorders, doing a really good audit of home safety. And here are some questions I've included for you all who work with people who self-neglect. What is the person's own view of self-neglect? Someone asked me this question earlier, is this self-neglect intentional or unintended consequence of something else? Like that severe depression we talked about. Is this long-standing pattern or something new or recent? What strengths does this person have? Or what recent changes have they experienced? Is there a link between their self-neglect and their any kind of disability? Is substance use involved? So again, here are some red flags, for you all in your assessment. For my gentleman in Tillamook, medical findings were the red flag for us. I also mentioned infestation, this for the gentleman I work with, who himself had maggots infestation. It was very dire. Cognition, impaired cognition. By the way, long fingernails and toenails. Let me tell you, I've had many cases where I've had that, where that for me was a red flag. Where, you really can't walk and do much with your hands and feet if you have those kind of curling toenails. And fingernails often filthy, and which was causing infections. Impaired cognition, like we talked about the correlation between dementia and self-neglect. Their functional ability, whether they're using a device or their mobility, their lack of social networks, any kind of mental health finding. And so, remember we talked about building trust and really understanding the person to really have a person-centered approach. And so very often, we look at like ADL care. Their hygiene is so poor. I just told you, which includes just odor, or they're just filthy, their clothes are dirty. And so really targeting your support. I'm just taking one such example as ADL care. What is the actual task you want them to do? Do they have the equipment to do it? Do they have the physical and mental capacity to do it? Who could help them do it? Are there some alternatives that we can put into place to, keep it at the mild end of neglect so it doesn't escalate to, more dire? So really looking at targeting your approach to asking those questions. And here are just some suggestions for direct work with people who are at risk. We talked about multi-agency. APS, do you routinely work with mental health? Do you call in mental health or your older adult behavioral health specialist? Or do you reach out to the primary care physician or the primary care team? Because it's really multi-agency work. It should be person-centered. Acceptance. Non-judgmental. It's easy to make judgments, right? About cleanliness or lifestyle. But accepting that everyone is different. Empathy. And that's sometimes a tall order when you can't understand why someone is doing this. Patience and time, which is sometimes in short supply in our work, right? Where it's huge caseloads, very little time. Trust by building to agree on small steps. Reassurance. The person, remember I said how we have this cultural narrative of autonomy and independence, that everyone is afraid that you're going to take that away or put me in a nursing home. How do you give that reassurance that, hey, you're not going to lose control. I want to help you with this. Bargaining. Exploring alternatives. And like not giving up. Here are practical tasks. I already talked about multi-agency involvement. Doing a risk assessment, doing a capacity assessment, mental health assessment, contacting family, decluttering services, using other local partners. In many of my APS cases, we were using animal control. We were in touch with code enforcement. We were in touch with homeless services. I mean, many guardianship, mental health, occupational therapy assessment, help with property management and repairs. So these are all kind of practical tasks which should be part of your toolbox. But the challenges in our culture and in Oregon, adults have a right to make their own decisions until a court finds evidence to the contrary. Like I told you about my woman client in Wilsonville. Determining if a person who self-neglects has the mental capacity to make decisions for themselves, including decisions about endangering their health and safety can be difficult. By the way, we all have the right to make very bad decisions, even people who self-neglect. But what we need to figure out is, was someone who asked me earlier, is it intentional or unintentional? Because capacity can also fluctuate. And then finding someone to do the evaluations is a challenge. And then there is this constant tug of war, right? Between autonomy, independence, and your role to do good or beneficence for people who self-neglect. Autonomy requires your commitment to respect the decisions of competent adults, even if they're very bad decisions. While beneficence requires your commitment to act in your client's best interest. So when these values are in conflict, what do you do? How do you get support? Whom do you talk to? And so you essentially are doing a risk assessment. What are the risks? How likely will this dire thing happen? What level of harm is likely for them or for others? And then, does my client who self-neglects have the capacity to make these decisions regarding personal needs, health, and safety? Do they have the capacity to extract themselves from harmful situations, circumstances, and relationships? How do you balance that? So there are these kind of competing moral imperatives, right? Respect for autonomy, choice, self-determination, and our duty to care and promote dignity, which is beneficence. That's the kind of tug of war. Safety versus self-determination. When these interests compete, clients' right to exercise self-determination outweighs their safety. Why? Because people have a right to take risks. We all make bad choices, all of us here, right here on this webinar. That doesn't mean we are self-neglecting. We are choosing, right? But there are exceptions. When clients do not understand the risk and the risk or dangers are substantial, then it is warranted for us to step in. That's the key. So a reminder of what is mental or decisional capacity. It is the ability to understand and reason through a decision and the ability to act on it in the moment. So impaired executive functioning is an impairment where you have problems with understanding, retaining, using, weighing relevant information in real time and problem solving. So it's essentially decisional capacity plus executive capacity. Remember, walk the walk, talk the talk, walk the walk. I mean, you can actually do it, equals capacity. And this is what is used in healthcare, to assess capacity. Ability to communicate a choice, ability to understand information, ability to understand the situation and consequences of options that they're choosing, and the ability to reason about choices consistent with their personal values. So ultimately, it's a judgment about judgments about risks are a constant factor in self-neglect interventions. Remember, for the gentleman in Tillamook, the intervention was, hey, we need to remove him now and take him to the ED. While for someone else, you may work with them, build their trust, and start working on small areas of decluttering their home, for example. Risk, whether it is to the client or to others, is a matter of probabilities, correct? So you need to ask yourselves, are risks actually harmful? Do risk factors assert their effect alone or in combination with other risk factors of equal importance when you're trying to do this kind of judgment? Again, I bring you back to the slide from earlier, to look at the severity and the urgency. For that gentleman in Tillamook, the severity and urgency were at the highest level. If we hadn't intervened, he would have died, and it was an emergency task, remove him from the home. And so, yes, we've already identified what challenges we all face working in this area of self-neglect. Access. How do you maintain access to someone who doesn't want you there? Many older adults think they're just doing fine. I don't need you. How and where do we get help with evaluating capacity? How do you do that? Here are some barriers. Working with people can be challenging work. We've already identified that very early on in this presentation. They refuse support or fail to acknowledge the problems. As you know, the risk of self-neglect can be very high, and the options for interventions are very limited with limited resources. There can be pressure on all you professionals to take action, very often by the community and by family members. But very little can be done in terms of your legal authority. Sometimes sharing information is a problem, especially when the person is refusing to sign anything for you to share information. And then we've already talked about just the lack of those kind of specialty services, which are often needed for you to make a full assessment, such as capacity assessments. Again, if you're working with your primary care doctor or provider who knows the person, these would be the things that we would ask them to look at. Not just the doctor, but it's a team sometimes. Can they do a depression screening? Can they do a cognitive screening? Can they assess for their social networks? Again, I will leave this. I will have this in my PowerPoint so you can take a look at it when you get it. So really, the interventions will for the medical providers would be to reduce the burden of chronic disease. If they're diabetics, whatever, help them, or put in some systems of care where their diabetes could be better managed, maximize their functionality, if they have functional problems, really ultimately is to improve their quality of life. And this approach I really like. It is from England, again, knowing, being, and doing, which is called a relational approach for working with people who self-neglect. First is knowing the person and their history, and also your own professional knowledge about self-neglect, which I'm hoping in some small way you've expanded today. Being respectful, empathic, honest, and caring, in the moment. And doing might involve hands-on and hands-off balance, where you're either negotiating or building consensus. So I really like that this is this little icon about being, knowing, and doing, which is that relational approach. I love the term they use, hands-off and hands-on balance. So building consensus, that means working collaboratively on small steps with the person while negotiating larger ones and deciding what interventions would be essential, would be the hands-on. So I just thought this was a good way to encapsulate, that relational aspect of working with people who self-neglect. This is really from Israel, where this is the intervention scripts that social workers use. Immediate threat to life. You call immediately for medical or psychogeriatric diagnosis along with legal enforcement, which we did with that gentleman, by the way, in Tillamook. Potential threat to life. Social worker attempts to persuade the older person to accept treatment, move out of home, all of those mitigating interventions, and brings the case before a professional committee. Third, danger of deterioration in the absence of risk, offers varied means of assistance, negotiates services including cleaning or renovating the home, and then environmental nuisance, works with public health authorities about warning the person about public health laws. So this is their 4 intervention scripts that they use in their communities in Israel. Look at what were the top interventions selected by nurses, where they would be involved, like in the ED, or if you have access to a community nurse, Meals on Wheels, house cleaning, patient education, that was that health literacy, medication, simplifying medication regimens, and referral to mental health services. So be professionally curious. What is your client's view of this neglectful situation that you are seeing? Is this a long established behavior, or you're seeing remarkably new recent decline? What strengths does this person have? Are there any links to their self-regret to health, literacy, disability, mental health? And again, I won't go over this, but here are many questions that you can use if you are in this field, that you can perhaps use with when you are making an assessment or working with someone with who is self-neglecting. I like number 3. In order to minimize threats to your health and safety, what do you think would help you? I think that's open-ended, and you wait to hear what the person says. Also 6, what do you know about services that are available to you in your community? So again, we've talked some about risk assessments. Remember, I said it can only identify probability of harm. And so how do you balance, what are static risk factors with what are dynamic risk factors, that are constantly changing? And so a big part of your role, and I hope you get the support, is risk management. I liked, again, I can tell you UK is doing such wonderful work with self-neglect. Look at this little schema here, key aspects of making a positive difference. Practitioners found these 5 areas were key aspects that enabled them to work best with their clients who self-neglect. The importance of relationship, finding the person, like, who is this person? That would be that non-judgmental. Legal and health literacy that they obtained, creative interventions, and effective multi-agency work. I found this checklist, which I think any of you would find helpful in the work you do with anyone who may be self-neglecting. And you don't need to be an adult protective services. You could be a case manager, you could be a mental health therapist, or a QMHA or a peer. where you're looking at things, look at fire risk. And you're looking at benefits and drawbacks. So there's a whole list in this checklist that you can complete. Decluttering. What are the likely benefits and likely drawbacks if you were to mention that? Mental health services. So this is a really handy checklist for you to use. I'm going to skip over this. I love this 5-minute coaching. If you're a supervisor or manager, what options do you see regarding this situation? What do you see as the challenge? What are your thoughts about the best way to approach this? What might get in the way? What do you think are next steps? How can I support you? When can I check back with you? This is the 5-minute coaching questions. And I'm asking you, look at this diagram below. Consider who can provide these key components of an effective strategy for managing the personal experience of self-neglect. Remember, I said it is challenging and hard work. Do you have this wherever you work? And I'm not only talking about APS. You get good, effective supervision. You have peer and collegial support. Written guidance, like in policy, practice, and training manual. Resources and sources of specialist advice and support. Now look at this and think about where you work. Do you get this? And because this is such challenging work, taking care of yourself is paramount. And I'm not going to go every one of these, but all of these can be used right by any of you. Practicing mindfulness, regular sleep routine, know your stress symptoms, know your stress symptoms precursors. Create a personal mantra or personal mission of why you do this work. Take a break when you need it. Here are some screening tools that I recommend, and I'm hoping Janine and Angela, y'all can provide people with some of the more frequently used ones when y'all send this out. And then report and refer, And you can report to Adult Protective Services, but you can refer to mental health, animal welfare, health, all kinds of agencies. That's what we used to do in Clackamas County. So the takeaway, it is multi-agency work. It should be person-centered. It should be non-judgmental and acceptance of the person who self-neglects. You need to be empathic and patient and have that ability to build trust, give reassurance, bargain, and negotiate. Remember the hands-off and hands-on. And so I have all my resources, all the bibliography. I did not put every one of them down, but many of them are also cited on the slides. So I'd love for you to take a moment to reflect on what we've talked today together. And if you all can put something in chat, that would be great. What is something new you learned today? What is one thing you will take back from this training that you will use to change your practice? And how do you take care of yourself? So those are the questions I'd love for you to answer. And I thank you, and I thank Angela and Janine for inviting me. I'm going to stop sharing now. And, I think I've saved time for questions, comments. If possible, if people can put their cameras on, I'd love to see you. There are several I can see. Otherwise, it looks like one big black hole to me. I don't know, Angela and Janine, whether there were any questions or any other comments.
There was one question. It
Uh-huh.
disappeared though, but I thought it was a good one. I don't know if Heidi is still here, but she was asking about assessments, sample assessments. You know, when someone doesn't work in the mental health or healthcare, you know, field, uh, what are the assessments that could be utilized outside of those areas?
So is Heidi asking for like a sample template of an assessment for self-neglect? Did I get that right?
Yes.
I believe so, yeah.
I mean, I don't have a sample template, but I can certainly look and see if we have, if I can find one, and definitely think about what I used to do and put together a template. Though I may not be able to do it very soon, you know, I may pull together a small group from our specialists to work on a sample template. Absolutely, we can do that. And
Yeah, that
that's
would
a
be
good idea.
All right. Yeah, that would be amazing. I don't want you to do a bunch of extra work, but I work with people who are houseless, but I'm not like specifically in a mental health or a physical health
Sure.
field.
Oh, it makes sense. Absolutely. Yes.
So I just wondered what was out there. Thank you.
Anyone, was there anything new anyone learned today? It may not have been new, but you know, it kind of was reiterated, you know, and that you're going to take that back and change your practice.
There were a few comments about how they really like the idea of open-ended questions and mitigating harm and asking the client what would help you. So I think that was great.
Okay. There obviously was an interest in this topic that, you know, so many people came. Actually, many more had also registered, you know, so I'm glad you all are here today. So thank you for coming. And really, we have time. If you are brave enough, you want to say something, you can just unmute yourself and make a comment or ask a question or maybe share an experience.
Hi, this is Mandy. I have a question. I actually, as a clinician as well as working as an older adult behavioral initiative specialist, of course, I wouldn't have an RI, so I wouldn't be able to give a name, but we do have some cases here. I have a case that is very serious like that and just came back on the radar for me yesterday because we got an APD report because I'm also an abuse investigator for Oregon Health Authority. Are you able to consult with me at all? Or would that be okay?
Yeah, I consult all the time. Like I said, I was recently consulting with Tillamook County. So on that complex case,
what
yes.
the presentation you have given has been very helpful to me. I'm really looking forward to the PowerPoint. I actually have learned a lot. And I've been working with him for years, and he came out of another county, and progress is not, we can't not get progress in this area.
Okay.
So I have some real concerns, particularly when you talk about potential of death to them and stuff. And
yes.
Okay, great. Thank you.
I see Susan wrote something. Hi, Susan. Always good to see you, or see you in quotes. I'm seeing.
Do you want me to read it?
Yeah, could you please? Yeah.
Yeah, she says, new takeaway. While we as staff know this, emphasis on creating relationship and trust, especially when pressured to stop working with individual by some supervisors.
Yeah.
Also, emphasis on multidisciplinary approach. This whole training was invaluable, and I will be sharing with our staff. Really, really looking forward to PowerPoint. Thank you.
Thank
and then
you.
also emphasis on assessments.
Yes, and I'm really talking from my experience. I was for 10 years the mental, geriatric mental health specialist in Clackamas County, and we had that team where, I was like the mental health part of the team. So, yeah.
I had one other question because we're working on a case right now which hit everything that was talked about. And I've been pushing for assessments. So every time there's been an event with this person, it's working on, okay, how do we get an assessment for that? How can we incur that assessment? But one of the things I'm wondering is, we have a special case where we have a person from a business who's interfering with work with this person and trying to push them in another direction. Have you ever had that type of situation where you're working with an individual, but now someone from, say, a for-profit service is jumping in and taking over or trying to take over, and eventually now our individual has said they do not want to work with that person anymore?
I would say having a collaborative meeting with all parties, would be a very good thing. So making it clear, like what's the plan, would be key. There's also that whole concept of undue influence. I know this is another non-profit, but individuals can also have that undue influence, on a person who may be, somewhat compromised and can easily be swayed. So that is a real concept, and it's upheld in the court, by the way, for elder abuse, undue influence. So I would recommend having a collaborative, like you can even call it a coordination meeting.
Okay.
So it's kind of like non-threatening, so that you're really coordinating care, because it seems like, there are 2 or 3 players now. So let's coordinate care so that we really focus on the best interest of this person. So,
thank you.
yeah. Anyone else? Angela or Janine, is there anything else?
Don't see any other comments, and I
Okay.
didn't hear any feedback, but thank you so much, Nirmala, for today's training. That was an excellent training. You will all receive a follow-up email from me with the slide deck from today's training, as well as NASW evaluation if you are requesting CEUs from NASW. And then you'll also receive a follow-up email from Portland State University Institute of Aging asking for feedback, and you will receive a certificate of completion with that after you've completed that evaluation. You'll also receive the slides and recording. And thank you all for being here today.
Thank you all. Thanks, everyone. I'll see you maybe next year. Bye.
And then, of course, our upcoming trainings with Advanced Care Planning with Angela on August 14th and Mental Health Advanced Directives on September 11th. We hope to see you then. Thank you. And yes, Mandy, I will send out a